Hi, welcome to our upper extremity venous duplex examination lecture. Hopefully you will find this a little bit helpful in getting you more comfortable with these exams. I know sometimes the anatomy in this area can be a little bit challenging, and so we'll work with you a little bit during our lab time to kind of optimize your comfortability with these. So let's go ahead and get started. So the objectives for today are to describe the components of your upper extremity venous system, including all the anatomy, define the normal image and Doppler characteristics of the venous system, identify the image characteristics consistent with acute and chronic thrombus. Most of these you're already going to know from our previous lectures. Describe the Doppler waveform characteristics associated with various pathologies. These can vary slightly in the upper extremity versus the lower extremity, so this will be a little bit of new information here. And then list the risk factors associated with venous thrombosis in the upper extremity. So considerations when we're scanning our upper extremity, techniques, maneuvers, signs, and symptoms are going to be similar to the lower extremity venous study, but not exactly the same. So we're going to find slight differences here, but once you're familiar with what you're expecting to see, you can feel a lot more confident in your scanning. The three major significant differences between the upper and lower extremities is that with our lower extremity, we often get thrombus due to stasis, meaning when we're sitting for long periods of time or on bed rest or something like that, we can have clot generally start forming in the sinuses of the leg, the soleus sinus, and then it can extend into the veins. Well, in the upper extremity, because it's rare that our upper extremities are very static for very long, as well as that we don't really have any of those sinuses to originate clots in, we're going to find that it's quite a bit less common to find a clot caused by stasis. Another major difference is in the lower extremity, we really concentrated on the deep venous system because that's where the most dangerous clots typically form. And when we're looking in the upper extremity, it's really the superficial veins that we're most concerned with because they're at higher risk for thrombus than our deeper veins. Now, one of the reasons that is really feeds into the fact that most of our upper extremity venous clots are due to trauma. And if we look at what veins we are typically accessing, it's going to be some of those superficial veins. So that is one of the common causes of having these superficial vein clots be a lot more concerning than our deep vein clots. We also know that upper extremity venous anatomy is more variable than lower extremity anatomy, so we'll see more significant differences between patients. So that can range from 1 versus 2 veins in a system or the location of the veins themselves. So signs and symptoms are going to be pretty familiar. When we have a clot, we expect some swelling because that blood that should be returning through our venous system to our heart can be caught up behind a thrombus, and it can cause some edema in that area of the arm. We also can find a palpable cord, which means a clot that's hardening a vessel that makes us feel like there's a cord beneath the skin. Erythema or redness of the skin is also a common sign and symptom to both lower and upper extremity thrombosis, as well as pain and tenderness. And that's really from that backing up of venous blood into the tissues. Now, because of the location, facial swelling, especially if the clot is affecting the veins that either drain the head or that receive blood from the venous system coming from the head and face, if those get backed up, it can back up that swelling into the face. And we can also find dilated chest wall collaterals. This would indicate that there is some sort of superior vena cava thrombosis, which is causing a backup into that whole upper extremity and even into the neck and head and face, which would cause the production of collaterals to try and bypass that thrombosis. So the signs and symptoms may be associated with the presence or history of indwelling venous catheters. So we know that PICC lines, different catheters such as that are going to be really common in the superior vena cava or pardon me, in the subclavian or in the axillary region. And so a lot of times these are actually the initial cause of a clot. Signs and symptoms may be used on asymptomatic patients prior, the upper extremity venous analysis may be used on asymptomatic patients prior to catheter or pacemaker placement to confirm the placement of these devices. And then finally, it's evaluation in patients suspected of having a pulmonary embolism, and that they know that that embolism likely came from somewhere. So the likelihood that it would have been either a deep venous thrombosis of the leg or possibly a superficial venous thrombosis of the arm can cause us to go look in that region. So like with the lower extremity thrombosis, we know that Virchow's triad is also going to be an important predictor of the probability of a thrombus in the upper system. So remember, the three components of Virchow's triad is stasis, which, as I just mentioned, is a little bit less likely of a contributor to the upper extremity system than it is to the lower extremity system. However, hypercoagulability is going to be equally associated with both, because if our blood is more likely to clot, it's more likely to clot throughout the whole body, not just in one region or another. And then finally, in the upper extremity, because we are accessing those veins much more frequently, or the physicians are, that vessel wall injury is much more common a cause of our upper extremity venous thrombosis. So things like catheters, needles to our arm veins, or our subclavian veins, such as PICC lines, IVs, etc., those are all going to put a patient at higher risk, especially if they're hypercoagulable for a thrombus in the upper extremity. Another association is Paget-Schroeder syndrome. This is where we have venous thrombosis associated with compression of subclavian vein at the thoracic outlet. So because of the muscular components of the pectoral muscles and then that non-mobile clavicle, some of that pressure from the muscles internally exerting pressure against that clavicle can cause compression of the subclavian vein and cause obstruction of the thoracic outlet. And when that thoracic outlet gets obstructed, then you're more likely to have a thrombosis there. This is most commonly typical of our young, athletic, muscular males because they build up those pectoral muscles, which then push upon the clavicle and can compress that subclavian between the two. Now, when we look at this exam, the exam is going to be similar in technique as to our lower extremity. When we have a vein, we're going to want to see if it compresses. Now, there are certain portions of this exam where a vein can't be compressed because of its location or because it's underneath a bony area or something like that. So we'll have to cause that coaptation of the vessels in some slightly different ways. But overall, what we're looking for is a compressible vein, means that there's likely no thrombus there. We do use transducer compression performed over all upper extremity veins. That pressure, as compared to when we're doing a lower extremity venous, has to be a little bit more gentle usually because of their more superficial nature. So it's easier to collapse or coapt those vessels of the upper extremity in most patients than it is into the lower extremity. And sometimes if we can't find a vein, it's simply that we have it compressed and would have to release some of that pressure. And just like the deep venous assessment, we're going to want to compress those veins every 2 to 3 centimeters along the course of each vein to ensure that there is no thrombus that we could be missing. So in our B-mode images, we're going to be looking in transverse. We're going to be doing evaluation with and without compression, and we're going to be documenting our findings at every major venous structure. In our longer veins, that might be at the proximal, mid, and distal ends of the veins. In our very short veins, it would just be a single representative image of that particular vein. Now, to further assess those veins, or to assess veins that we can't necessarily compress, we can utilize spectral and Doppler waveforms and record these again of all of our major veins, with the longer ones proximal, mid, distal, with the shorter ones just at one representative area. So beginning of the exam, like you would for any other exam of your patient, you're going to want to obtain your patient history and evaluate their labs. So part of their patient history is to assess, since we know that they have a high risk of having a thrombus because of trauma, you want to assess their risk of trauma, recent medical exams, any recent catheter placement or IV placement, anything like that. Next, you'd want to make sure that you're evaluating their lab results. We know that a D-dimer can be loosely associated with a thrombosis, so we'd want to look for that. Now, we also know that any type of thrombosis can turn into a pulmonary embolism. So you want to also assess your patient's breathing, see if they have any dyspnea, anything like that. And then you can start your clinical evaluation. So when you're clinically evaluating the patient, we want to look for those signs of thrombosis. So looking for any edema, erythema, the redness of the skin, feeling for a palpable cord, anything like that would be indicative of a possible thrombosis in that general region or distal to that region. The other thing you want to do is take measurements of the arm. So you'd want to measure at the biceps, towards the elbow, and then in the forearm and wrist regions, and look for consistency and size between both arms. Now, this can be slightly different in the arms than it is in the legs, because we know that most people are either right or left hand dominant. It's not unusual that one arm would be a little bit more hypertrophic to the other arm, but you want to look for significant changes in edema and size between the two arms. When you feel like you have all of your patient's history, lab assessment, clinical evaluation complete, then it'd be time to have your patient go ahead and remove all their garments from their upper body and put a gown or drape on them. I would have them also remove any necklaces or anything that might obstruct your ability to easily scan in that manner. Bras should also come off, or at least a bra strap tucked under the axillary region. Once you've done that, you can have your patient put a gown on, or probably most effectively have them drape the unaffected side so that you have easy access to the affected side. You'll typically begin the exam with the patient's affected arm down to their side while you scan their neck and upper proximal region of their upper extremity. And then as you proceed through the exam and need better access to the axillary region, then you might have them abduct the arm and lay it out laterally so that you have better access to those veins. Finally, you want to clearly explain the exam. Let your patient know that they're going to be hearing some noises. Let them know that you're going to be compressing, and let them know that their assistance with the exam can make it go much more smooth and quicker for them and be more effective. Finally, you're going to want to select a high-frequency linear transducer, and you'll be utilizing that transducer mostly for the superficial veins of the arm. It's also very important to have a lower frequency transducer where you're going to get a little bit better depth. So having a curvilinear or maybe even a sector or vector transducer that you can utilize to scan behind the clavicle, it can be very useful to have on hand, because in accessing some of these veins of the upper thorax can be really challenging. You probably won't get it done with just a linear. So make sure that you have that linear option as well as one that has a lower frequency, greater depth ability. Really quick to begin the process, let's start with our anatomy review. So if you see here, we have a nice patient. You can see this is their superior vena cava. Now, when we're thinking about the venous system, we have to remember that the blood is all going towards the vein. So it's one approach where you can learn the vein, or excuse me, the major veins outward, or you can look at it as the blood drains. So let's start by that matter. So we're going to look here in most distal in our fingers. We're going to be collecting that venous blood through those digital veins. They're going to be communicating across this deep palmar arch, and then they're going to be ascending up the arm as the radial and ulnar veins. Those radial and ulnar veins are going to come together in the antecubital area, and then they're going to ascend via the brachial vein up the arm into the axilla region. Now, if we go back here, we see that those were our deep veins. Now, if we look at our superficial venous system, we'll see that we have these superficial veins that are going to be traveling parallel with those deep veins. Now our superficial vein on our ulnar side is going to be called our basilic vein. And here you see it coming up to the antecubital region there. Then we see that we have a median antebrachial superficial vein, and then we have our cephalic vein. Now all three of those are going to come up to this antecubital region, and they are going to communicate via the median cubital vein. Now that doesn't mean that's the end of these veins, it just means that's where they're communicating. Now on our ulnar side, we had that ulnar vein go up, it connected with the radial vein, and they produced the deep vein known as the brachial vein. Now as we look at the superficial side, our basilic vein is going to come to the antecubital, mix with some of that venous blood from the cephalic, and then it's going to continue up until it combines with our brachial vein. And once those two veins combine, we call it then the axial vein, right here. Okay, now on the radial side of our arm, or the lateral side of our arm, we followed that cephalic vein all the way up. It mixed a little blood here in the median cubital vein, but then it continued up against the lateral, at the lateral aspect of our arm. And when it finally comes in and meets with that axillary vein, then we refer to it as the subclavian vein. Okay. Now our subclavian vein is going to come in, and it is going to connect with our jugular veins, and then it becomes the brachiocephalic vein, and it's actually that brachiocephalic vein that then dumps into the superior vena cava. So here we have a deep system, which is our radial and ulnar, coming together to create the brachial. We have our superficial system, which is really our basilic and our cephalic, coming in. Our basilic joins with that deep system brachial and produces the axillary. When the cephalic dumps in, then it becomes the subclavian. And then finally, when our neck veins dump in up here, that's when it becomes our brachiocephalic, and then that will terminate into the superior vena cava. Now, when we're going to start our protocol, we usually want to begin in the neck. So the first vein that we're going to look at is the internal jugular vein. Now, the internal jugular vein is going to run just lateral to our common carotid artery, and it's very compressible, as you'll know if you've scanned a lot of carotid arteries. So when we're looking at our internal jugular, we want to assess this in transverse from the superiormost portion we can identify down to where we see it actually connect with our subclavian. So you want to assess it in B-mode imaging in transverse with and without compression, and you'll want to document that compression at proximal, mid, and distal regions. You can do that with dual screen. You can see here a nice distended jugular vein here next to your common carotid artery. Adequate compression would fully compress this jugular vein, but leave your common carotid open. If you're getting compression that's actually collapsing the common carotid, then you're pressing too far, and you may be trying to compress a thrombus that you're just not visualizing. Now, this image to me is a little bit hypoechoic. I'd probably turn up my gain a little bit to make sure that they're not missing any thrombus that could be in there. Now, one quick important note is that if a patient is erect or upright, that decreases the pressure on that jugular vein and can cause it to not dilate. And so if you're having difficulty identifying the jugular vein, you can always lay your patient's head back more, and that should allow you to get a better view. So once you've compressed that internal jugular vein all the way down every 2 to 3 centimeters and evaluated it for compression, then you can add your color flow. So you want to make sure, just like we did in the lower extremity venous system, that we're filling that vessel completely with color. Make sure that your settings are appropriately set with appropriate color gain, appropriate scale, and all of those considerations. You can evaluate it in transverse and long with color to assess for any mass effect that a thrombus may be having in causing that blood to not fully fill the vessel. Once you've completed evaluation in long and documented that, then you would add your spectral to it. Now, One of the interesting things that we find with the spectral Dopplers of the upper extremity is that because it's so close to the proximity of the heart, sometimes we can almost see a little bit of that pulsatility reverberate into that venous system. So in the lower extremity, we're far away from the heart, we didn't really see any pulsatility, or we shouldn't have seen any pulsatility. We had just that nice phasic flow of the venous blood that matched when my patient's thoracic pressures were changing. But here we're getting that phasic flow caused by the changes in thoracic pressures, but we're also seeing this bit of pulsatility because of recoil from that right heart. Okay, now once you're done with your internal jugular vein, some site protocol will require you to also demonstrate the external jugular vein. This is a smaller vein to the lateral of your internal jugular. It doesn't fill as much, so it can be a little bit more difficult to identify, but you'd want to evaluate that external jugular vein in the same manner you did with the internal. You'd want to follow it from its origin, or where you could identify its origin, all the way down here to where it connected with the left subclavian. As I said, this is not included in all site protocols, so it's a good idea to be aware of how to do it, or that you might be required to do it, but in all likelihood, a lot of places won't be having you do this. You're able to identify this external jugular vein as a vein that has no accompanying artery. So if it's right next to that common carotid, that gives you your heads up that you're in the internal jugular vein. This one's also very close to the skin surface, and so it can be easily compressed without intention, so make sure that you're using a very light hand on this. With this, again, I've just mentioned you're going to evaluate this in transverse with and without compression every 3 centimeters. You'd want to document with respective or representative images at the proximal, mid, and distal. And then you would want to add color flow, and then also you're going to want to add your spectral Doppler as well. Now, once you're done with your internal and your external jugulars, now we're going to go farther towards the heart. Now you're going to want to look at this brachiocephalic vein right here. Now this is one of the most challenging veins to visualize because we actually have to angle our transducer probe posterior and below our clavicle to pick up this vein. The other thing with this vein is because it's really protected by our thorax and our clavicle, we're not going to be able to compress this. So we have an additional manner in which we can try to compress this vein, but really a lot of our assessment is just done by watching the lumen fill with color. So for this one, if I had it available, I'd probably try to change to a sector or a vector probe with a very small footprint. If you don't have that, you may have to go with a curvilinear and just make the best contact you have. So we know that that brachiocephalic vein really originates when our subclavian and our jugular veins meet. So you'd want to follow that jugular vein down, and when you see it reach that subclavian, anything from that point toward the SVC is going to be your brachiocephalic vein. Again, this cannot be compressed because of the bony anatomy around it. So what we're going to do is we're going to document it in B mode and make sure that you have your gain settings appropriately set to identify the vessel. And then you can have your patient do something called a sniff test. So you have them purse their lips closely together and take a big, quick breath in. And when that happens, it increases that thoracic pressure enough that if that vein is patent, you should see it compress. So you'd want to document it in B mode, evaluating it just open, and then with the sniff test to make sure that it coapts. The next way you're going to evaluate it is by adding color flow. In here, you really have to assess your color flow, make sure that your settings are appropriately set as to demonstrate whether you're getting full fill of that vein or if there could possibly be a thrombus in there that's causing a mass effect in changing the shape of the lumen because of a thrombus. And then finally, you'll want to do spectral waveforms. Now, this should again demonstrate physicity, but you will also definitely see pulsatility in this as well, due again to the proximity of the heart. So here's a great image of where we're seeing the internal jugular vein dive deep into meet with this subclavian vein. From that point on, here is our brachiocephalic vein, right in this region. So you can see that this is very challenging to identify, but they have good color flow here, which is demonstrating that, that the vein is patent. Once they add the spectral Doppler in, you're definitely seeing that pulsatility, but you're also seeing some of that phasicity too, and that's what you're going to expect to see here. Now, if you had a lack of color flow in that region, you would be suspicious for a thrombus. However, you don't want to jump to any conclusions until you make sure that your color settings are optimized. You might have to decrease your scale, you might have to increase your color gain, and do things like that to make sure that you're not just missing color that really is there, because that would be catastrophic. Okay, now from your brachiocephalic, then we can go out to our subclavian. Again, the subclavian part of it, the proximal part is typically going to be above the clavicle, but then as you can see in this image, it's going to dive below the clavicle. So again, you may have challenges in documenting compression with your subclavian vein here, and so you're going to be highly reliant on angling the probe under that clavicle and utilizing your color imaging to make sure that you're assessing it correctly. So with your subclavian vein, we know that anything beyond where that jugular combined with it to make the brachiocephalic, anything lateral to that would then be your subclavian vein. It's accompanied by the subclavian artery, and it gets a little bit more superficial than that brachiocephalic. Again, it's difficult to compress due to the clavicle, so you can utilize that patient with taking the pursed lips with a quick deep breath to compress that vessel again in areas where you may not be able to assess it with compressions. When you're doing your subclavian, you're going to evaluate it in transverse B mode with compression or with that pursed lips test, and then you're also going to evaluate it in long in B mode as well. You're going to want to obtain a representative image of your subclavian vein. Usually this is relatively short vein, so probably a single representative image of B mode transverse, B mode transverse with compression, B mode long, color long, and spectral long. Okay, then we know that our subclavian really is formed by the confluence of our axillary vein and our cephalic vein. So we're going to be looking at these veins next. So we're going to stick with the superficial vein, our cephalic vein. The cephalic vein travels superficially across the shoulder and along the anterior lateral of the biceps muscle. It communicates with the median cubital vein, as we discussed, with the basilic vein in that antecubital fossa. Now, at some points, depending on the patient's anatomy, you may end up having two cephalic veins in that region. So with your cephalic vein, you're going to want to identify it at that proximal region where you see it connecting with the subclavian. And then you're going to want to follow that cephalic vein down the length of the arm with compressions every 2 to 3 centimeters as it goes down the radial side of the arm. In this vein, you'll want to document in proximal, mid, and distal because it is a long vein, it is superficial, and so it's at higher risk for clot. Now, once you've evaluated in proximal, mid, and distal with your B mode imaging and transverse, then you can assess it in long. And this is where you're going to want to add your color on. So you can see an image here. Here's where they have added their color in, and they're going to want to assess it in proximal, mid, and distal in long, and in long with spectral. Now we know that it is going to communicate with that basilic vein that's going to be running up the medial arm. And so that communication is going to be in that medium cubital area. So we can see right here, this median cubital vein. So if we've already assessed the jugulars, the brachiocephalic, we went to the subclavian, we followed it out until where we see the axillary and the cephalic, and then we chose to follow the cephalic. We documented it in proximal, mid, and distal. Now we need to look at that median cubital vein. We're going to evaluate that median cubital vein just in this one general region, and you're going to want to do that with your typical technique. So with your median cubital vein, you're going to want to assess it in B mode, compressing every 2 to 3 centimeters, and evaluating it, taking a representative image there in the cubital space. Now we know that on the medial side of the median cubital vein, we have the basilic vein. So that's going to be our next step. But first, because that median cubital vein, as you know, especially if you've worked in general areas of radiology, this is one of the places we love to put catheters or IVs in, especially for contrast exams, because it's a nice chunky vein that is really large, and we can pump lots of contrast into a patient quickly in this region. So therefore, especially if a patient is post-procedure, this might have been a vein that was experienced some trauma, and so this would be an area where you'd be more likely to produce a thrombus. So you're going to want to compress this in B mode, transverse with compression, take your representative images, and then go to long, evaluate it in B mode and long, and then you are going to want to add color to it, looking for any deviation of that color from filling the lumen, and then you're going to want to look for your spectral. And your spectral should be, as we get farther away from the heart, you should see more physicity with a lot less pulsatility. Now, we know that cubital vein, or that mid-cubital vein, communicated with our basilic vein over here. So we can go look at, so this brings us to our axillary vein. So we knew that when we saw the cephalic vein branch off of the subclavian, or really flow into the subclavian, the other component that it met up with to develop the subclavian was the axillary. So the axillary vein is formed from the basilic and brachial veins that combine to form this axillary vein right in the distal axilla. Then that axillary vein is going to come proximally and superiorly through the axilla region, and then it's going to meet with that cephalic vein and develop the subclavian vein. This is considered a deep vein, and it is accompanied by the axillary artery. It's going to run through basically your patient's axillary region and ultimately create that subclavian vein, as I mentioned. This should be evaluated every 2 to 3 centimeters in transverse with the B mode, with and without compression. Since it's a relatively short vein, you can, depending on your site's protocol, you can probably take one representative image of this axillary vein, but you would have to evaluate it with compressions every 2 to 3 centimeters. Once you've evaluated it and the whole thing compresses, then you can go to long, evaluate the vein in long B mode, in long with color, and then in long with your spectral. As we're getting closer to the heart here, especially if there's any congestive heart failure, you might be finding just a little bit of that pulsatility in this vein, but it should be significantly less than that in the brachiocephalic and subclavian. So here you see the axillary vein accompanied by that axillary artery, and you see them side by side. Here's with color. You should also document with no color with B mode in your compressions here. Here you see it accessed from more superior in the shoulder. Then here is where you're in the more axillary region, scanning up and out, where this is where you're scanning outer shoulder in. Okay, so we've now been through our jugular veins, our brachiocephalic, our subclavian. We followed that cephalic all the way down. We came back up and looked at that medial cubital vein, And then we assessed this axillary vein, excuse me, going down. Now we're going to follow up by looking at our brachial vein. So our brachial vein they're typically paired, they're deep veins, and they're formed by the junction of the radial and ulnar veins at that antecubital fossa. Now we know that our radial and ulnar veins are part of that deep system, so when they come together, they're going to form a vein that's also part of that deep system. Now remember, our brachial vein forms there at the elbow or the antecubital space from radial and ulnar arteries, and then it's going to ascend up the arm until it combines with the basilic vein. And once it combines with that basilic vein, then it forms the axillary vein. Okay. Now, this brachial vein you want to assess from that area where it has become the axillary vein and follow it distally, compressing every 2 to 3 centimeters in transverse in B mode, taking proximal, mid, and distal comparisons with compression and taking representative images at those 3 levels. Once that's completed, you want to evaluate in B mode in long and add color in long and assess with spectral. So here you can see those paired brachial veins and how you see the basilic vein over here to the left of it. It's getting close to the axillary region where these are all going to combine to form that axillary vein to continue on from there. But if you see an artery with it, that's going to tell you it's a deep vein, so that's going to be your brachial, whereas no artery, that would indicate superficial, and that would be your basilic. Okay, so now we're going to go down and we're going to look at our radial and ulnar. So those radial and ulnar are going to come together, like we said, at this antecubital space, and then that produced our brachial that we just spoke about. So our radial veins, this is always going to be on the thumb side of our arm. And so these are not always included on site protocols. And so it's a good idea to know how to do them, but you may or may not be required to. Usually these are paired, they're deep, they're very small, and they rarely thrombose, and that's why many places leave it out of the protocols. However, to be thorough, or if that area of the arm is symptomatic, it's probably going to be a good idea to look whether it's on your protocol or not. It's going to be, because it's deep, it's going to be accompanied by an artery. It's going to be on the anterior lateral or the thumb side of the forearm. And you can find this down toward the wrist area, and you can evaluate it every 2 to 3 centimeters with compression in B mode in transverse, up to where you see it connect with the ulnar vein. You can look at it in B mode with compression, proximal, mid, and distal, and then you can go long and evaluate them in long B mode, proximal, mid, and distal, and then you can go with color, proximal, mid, and distal with color and spectral. Now, if we look at the radial vein, we want to look at the ulnar veins. These are also deep, so they're paired and they're accompanied by an artery. That rather than being lateral forearm, now they're medial forearm. Again, these are not always included on a protocol. So if you do include these, you're going to evaluate the veins from the wrist region in transverse B mode with compression every 2 to 3 centimeters. And you'll evaluate them proximal, mid, and distal. And then you will turn on them, evaluate them B mode long, proximal, mid, distal. And then you'll add your color and spectral and evaluate them proximal, mid, distal. If you ever are uncertain, if you can't get them to fill maybe with your color, a slight augmentation can help fill both these and your radial veins. You can also check for augmentation to see that the vein is clear between where you're scanning and where you're augmenting. Those things can be very helpful in this region. So that really leaves us just with our basilic vein. So we knew that our basilic vein, now this is a superficial vein. So our basilic vein runs up that medial side of the arm. When it combines with the deep brachial vein, it's going to form the axillary vein. So we're looking at this last superficial vein where we know we're at higher risk for having thrombosis. So for the basilic vein, we know that it's going to form at that distal medial wrist. It's a superficial vein, so it is not going to be accompanied by an artery. It's usually the largest vein in the arm, and it often has two branches, one anterior to the forearm and one posterior to forearm. If you want to start assessing this at the wrist and following it up, you would want to evaluate both of those basilic veins. You would evaluate them in B mode transverse, compressing every 2 to 3 centimeters, taking representative images of proximal mid-distal from the wrist to where it confluences with the brachial, and that will give you a full assessment of that vein. Okay. Once you've assessed it in transverse with and without compression, then you would want to assess it in long B mode, in long with color, and in long with color and spectral at proximal, mid, and distal regions. You also have already, we know that this basilic vein is going to communicate with the cephalic vein via the median cubital vein. So you've already assessed that median cubital vein. So once you add this final component, you should have a really thorough assessment of the whole upper extremity venous system. Okay, so here you see that basilic vein. It's a larger vein. It has no accompanying artery, and you likely will have two of these. Now, here you see the ulnar veins. Here's the basilic. Ulnar veins have an artery. Basilic does not. Basilic is larger. All right, so let's tie this all together in a simplified protocol. So we're going to start out with our internal jugular vein. We're going to assess it in transverse with and without compression throughout the vein every 2 to 3 centimeters. Then we're going to assess it in long B mode, in long with color, and in long with spectral. Then if required, we can go to the external jugular vein. Now this vein is not paired with an artery, and it's more lateral to our internal jugular. We're going to assess it through its length in transverse with and without compression, in proximal, mid, and distal regions, in long in B mode, in long in color, and in long with spectral. Then we go to our brachiocephalic vein. Now we know that our brachiocephalic vein is the vein that is formed when our internal and external jugulars dump into our subclavian. So where we see that confluence of those veins, we know from that point toward the heart is going to be our brachiocephalic. Now this one, we're going to evaluate in transverse the best that we can. And because we cannot compress this because of the location and the surrounding bony tissue, we're going to have our patient do pursed lips breath, quick and fast. That should try to make this coapt. Then we're going to assess it in long with color and spectral. Now, just so you know, because of its lie within the body, it can be very difficult to get this in transverse. So sometimes you'll have to assess this fully in long. But that color and spectral is going to be essential, as well as that attempt at the pursed lip breathing. All right, so now as we're going out down our arm, we know that the subclavian was the vein that joined with those jugulars to create the brachiocephalic. So from on the lateral side of that confluence of the subclavian and the jugulars, where that brachiocephalic was formed, that's where we're going to identify that subclavian. Part of it's going to be above the clavicle, and then it will dive deep to the clavicle as you get more towards the arm. We want to assess that the best we can with transverse, with and without compression, using that pursed lip breath method to compress it in areas where we cannot compress with our transducer. If we feel like it's compressed well, then we're going to assess it in long B mode. We're going to assess it in long with color and in long with spectral. Then we're going to follow that out to its most distal component. Now, the subclavian was formed when my cephalic and my axillary came together. So the first one I'm going to follow is my cephalic. So off of my subclavian, I'm going to trace it back to the cephalic. Now, the cephalic is going to go on the superior aspect of your biceps and lateral aspect towards the radial side of your wrist. So you're going to, this is a superficial vein, so this will be not paired with an artery, and it's going to be very superficial and easily compressed. So you're going to want to follow this in transverse B mode, with and without compression, compressing every 2 to 3 centimeters, taking representative images at the proximal, mid, and distal regions, and then assessing again in long B mode, in long with color, and in long with spectral at proximal, mid, and distal regions. Then you can look at, and I don't have it on here, but the median cubital vein. That's going to be the connection between the cephalic and the basilic veins. And it makes sense once you've completed the cephalic to go ahead and add in that median cubital vein with transverse compression, long B mode, long with color and spectral. And then you can go up to the axillary. So the axillary is formed when the brachial and the basilic come together. So you'd identify that confluence of the brachial and the basilic, and you would assess then the axillary from that point to the point that the axillary and the cephalic join together to produce the subclavian. So you're going to follow that axillary up superiorly in trans with and without compression, compressing every 2 to 3 centimeters, taking a representative image demonstrating it with and without compression. Then you would go to long B mode, demonstrate it in long with color, and in long with spectral. Then you're going to go to the brachial. Now, the brachial forms when your radius and ulna combine. So you'll find your brachial's origin at about the anacubital space. You'll evaluate it in trans with and without compression, proximal, mid, and distal, compressing every 2 to 3 centimeters. Then you're going to go to long. You're going to do it in long B mode, proximal, mid, and distal. And you're going to do it with color and spectral, proximal, mid, and distal. Now remember, this brachial artery is a deep artery, or pardon me, brachial vein is a deep vein. It will be accompanied by an artery. If you haven't already done the median cubital, you can do it here. And then that radial and ulnar were the two that fed to develop that brachial. So now you can come down to the wrist, and if required, you can assess the radial in transverse with and without compression, compressing every 2 to 3 centimeters from that radial side of the wrist all the way up to the anacubital space where it joins with the ulnar. You'll also want to assess it in long B mode, in long with color, and in long with spectral at proximal, mid, and distal. Sometimes augmentation may be required to get these to fill. Ulnar, again, you're going to go now to the medial wrist, and you're going to assess the ulnar if required in trans B mode with and without compression, compressing every 2 to 3 centimeters in proximal, mid, and distal, and then assessing in long with color, and in long with spectral at proximal, mid, distal. Then you can finally wrap it all up by getting that last superficial long vein, the basilic. So this one, you're going to be on the medial aspect of the wrist. You can identify the basilic in that it is superficial, so it does not have an accompanying artery. You'll want to assess the basilic all the way from its origin at the wrist to its termination where it joins with the brachial to produce the axillary. You'll assess this in trans with and without compression all the way proximal, mid, and distal, and then in long B mode, proximal, mid, and distal, and in long with color and spectral in proximal, mid, and distal. So hopefully that's a little bit of a simplified protocol where you can kind of tie all these ends together, maybe make it your own if you don't have a good protocol at your site. You can make this your own, and it gives you a nice little checklist where you can make sure that you've seen everything that you wanted to see. Now, the upper extremity does come with some challenges. One of those was something we already mentioned, where our venous anatomy can be variable between patients, and so that can be a little bit challenging. We can also have some additional challenges when some areas we're having difficulty compressing, like those brachiocephalic or the subclavian veins, that we're going to have to rely on the use of color and other strategies to verify their patency. We can also have some challenges if a patient is post-catheter placement or they have a dressing or covering. It can complicate access. You have to be very efficient at trying to angle around these dressings and different things to get the images you want. significant edema and other things can also contribute to those kind of challenges. Okay, so the diagnosis. So how are we going to diagnose if something's right or wrong? So we know pretty much that the diagnostic criteria are going to be the same for the upper extremity as it is for the lower extremity. So we know that normal vein walls should coapt completely. By the time we're starting to see any distortion of a nearby artery, we know that we've applied enough pressure, and if we're not getting coaptation, then there's something wrong in that vessel, and you should be adjusting your 2D gain to try and identify a thrombus. We're always completing our compressions in transverse plane, because if we're in long trying to compress, we don't know if the vessel really compressed or if we just rolled our transducer off of it. Vessel walls or vein walls should always be smooth and thin with an anechoic lumen. Vein diameter can change slightly with respiration, as well as patient position, as we talked about with like the internal jugular. If the vein walls don't coapt, thrombus should be suspected. If we can't identify a thrombus, turning on color and looking for any deviation of that flow within the lumen can also help us make that assessment. Echogenic material should be observed with echogenic material should be observed within each vein lumen that has a true thrombus. So adjust your TGC, adjust your 2D gain to make sure that you're identifying that if it's there. We know similarly to in the deep system, an acute thrombus, these are harder to identify, they're newer, and they're not going to be as echogenic. It's a new thrombolytic pattern, so they can feel kind of spongy, they can be softer, but again, and they can be more compressible, so these can be harder to see, and so utilizing appropriate 2D gain and always assessing with color to look for the patency of the whole lumen is going to be very important with these, because these are the most poorly attached. They're most likely to detach and cause a pulmonary embolism. Chronic thrombus, just like in our other systems, as clot develops, it becomes more echogenic over time. It becomes more well attached to the wall, more rigid. And if it has completely obstructed a vein over time, usually that vein will just contract around the thrombus and hopefully build some collaterals to correct for it. Superficial vein thrombus will have the same appearance as deep vein thrombosis. We just want to make sure that we remember most of the time, if you're confused between which is superficial and which is deep, your deep is often going to be paired. It's often going to be accompanied by an artery, whereas your superficial will may or may not be paired and will not be accompanied by an artery. Okay, so here's just a demonstration of a vein here that does not collapse versus one that does fully collapse. Okay. Here you see this is a transverse image of a vein lumen, and you see only partial fill here, so it's difficult to detect that thrombus in B mode, but on transverse you see that it certainly isn't filling with color or flow, so there is some thrombus having a mass effect on the blood flow in that lumen. Here we see that same vessel in long, and if this is our whole lumen, there's a very small portion of it allowing blood flow through, so that would indicate more of an acute type thrombus. When we look at our spectral waveforms, we always know that with our venous system, we expect to see respiratory phasicity. So in our arm, when we take a breath in, our thoracic pressure is actually going to, if we take a breath in, our thoracic pressure instantly decreases, which is what allows air to move into our chest. When we breathe out, our diaphragm moves up and it's going to increase my thoracic pressure. So it's on expiration, you would see that stop of flow into the, from the upper extremity veins. On inspiration, you have a drop in thoracic pressure and you're going to see increased flow from the arm or from the jugulars into those main veins. So look for respiratory phasicity according to where your thoracic pressure is. Low thoracic pressure means forward motion. High thoracic pressure means stoppage of motion. Sometimes we can augment with distal compression. That will help us fill our veins. We don't want to augment a lot unless we're sure that there is no thrombus there. So that's another way to validate the patency of veins throughout your exam. Augmentation is not used as part of a protocol as often in the upper extremity as in the lower extremity, but it can be added to basically any of your spectral images to demonstrate the patency of the vein. We know that where we would see pulsatility in a lower extremity venous vein would be highly unlikely or concerning of heart failure. In the upper extremity, it's not as concerning because of the simple proximity of these veins to the right atria of the heart. When we have a complete thrombus, there's no spectral signal at all and no color flow. Partial thrombus can result in continuous flow as will proximal thrombosis or extrinsic compression. So you'll lose some of that phasicity if you have a partial thrombus. It'll be moving through, but it's not as reactive to the breathing. Retrograde flow is extremely uncommon except in the jugular vein when you're having reverse flow as serving as collateral pathways. And you can sometimes have arterialized venous flow if there is hemodialysis fistula or graft, meaning that you're going, it's almost like you've created an AV malformation where you're going arterial right to venous. And so you would see that pulsatility or that arterialized venous flow in those cases. One other thing that we can visualize, and sometimes we will have to visualize, is a venous catheter. If they've noted that there is thrombus around a venous catheter, it must be removed. These are going to be more the longer term indwelling catheters, such as a PICC line or something like that. Here you see an image of a catheter. You're going to see them as a parallel bright lumen within the vein. If they start to develop a thrombus on that, that is important information to convey to your physician right away. That thrombus will appear as either a low-level echo or an echogenic material around the surface of the catheter, depending on the age of the thrombus. It has to be removed if it becomes thrombosed. Treatments of an upper extremity thrombosis are going to be really similar to what they are on our deep vein thrombosis. They could use anticoagulation, catheter removal if a catheter is present, thrombolytic therapy to break down the clots, surgical compression, such as those compression sleeves, things like that. Conservative treatment where they may watch and evaluate, and other treatments as they're developed. So in summary, the upper extremity venous duplex can be challenging. It has a lot of similar conceptual ideas to our lower venous system, but we watch our superficial veins more closely in our upper system than in our lower system. Making sure that you have a good standard protocol to get you through the exam is going to be very helpful. Identifying thrombus is going to be really similar to how you would in any other part of the body, and you would be able to identify it by age according to its echogenicity. If you come across a vein that cannot be compressed because of its location, you can always utilize color to look for the vessel to fill, or you can try to do that pursed lip breathing technique if possible. If a thrombose is noted, it can be treated, and it most of the time is treated because of its probability or possibility of contributing to a pulmonary embolism. If there's a catheter present with the thrombosis, it must be removed. And that's it for today. So I look forward to hearing if this has been helpful and if it gets you more confidence in your upper extremity venous studies, because I feel like that's something I hear about frequently, that a lot of the sonographers didn't feel properly trained in or don't feel as confident as we'd like to. So hopefully this is one step into getting you closer to that confidence. Have a great week.